Good evening, Gaurang Shah, sir.
Good evening. You are answering today?
Yes, sir.
Good, good. Who else is? Ojas is answering?
Yes, yes, sir. I'm also there. Good evening, sir.
Both of you have read about topic, na?
Yes, sir.
And today, na, we'll be discussing at length till the follow-up.
Okay, sir.
Okay. Yes,
From
sir.
the beginning till today. So, it will cover most of the part.
Right.
Yes, sir.
So how was the study? You are appearing, means your exams in July.
June, sir. June.
10th.
9, 10, 11.
9,
9, 10, 11.
Hello, Mr. Dr. Ojas. Can you
Yes,
hear
sir.
me?
Yes, sir.
Hi, I'm Dr. Achint. There's a lot of background disturbance from your speaker. Can you just switch off the fan? Fan might be the probability.
Okay. Yeah. Is it better?
Yes.
Switch off the fan.
Yes,
Is it?
it's better. Huh?
Okay. Okay. Yeah. Sorry, sir.
Gite sir, we wait for 5 minutes, 2-3 minutes, and then we start.
Yes, sir.
Okay, sir. Yes, sir.
So today Abhishek and Ojas,
Yes, sir.
yeah, these two are answering. I think we should start now.
Okay, sir.
Okay, fine. Achin, start.
Yes, sir. A Muslim gentleman, 24 years of age, resident of Mumbai, came with complaints of left flank pain since 3 months.
So yes, Ojas.
Yes, sir. So I will like to ask about the nature of the pain, whether it was continuous dull aching, whether there was pain was radiating, what are the aggravating and relieving factors, whether there is previous history of pain, whether there is associated history of fever or any GI symptoms associated with the pain, any history of a trauma associated with the pain, and and also the onset duration and the progress of the pain.
Abhishek, anything you want to add into it?
Sir, first of all, I'd like to characterize the pain, onset, duration, progress. What is the exact site of the pain, character of the pain? Is it radiating, non-radiating, aggravating, relieving factors, if any? And furthermore, other than that, sir, I would like to ask about the associated factors associated with the pain, whether he has any fever associated with the pain, any lower unit tract symptoms associated with the pain, dysuria, any kind of dysuria, hematuria, any other associated factor. If any, I'd like to expand on those also. Other than that, I'd want to ask about the past history associated with this pain, if any. Has he underwent any kind of surgery in the past? Has he had similar episodes of this kind of pain in the past? If so, what was done for that pain? Was he hospitalized or not? Any kind of medication was started or not? Thereafter, any kind of instrumentation was done regarding this pain or not? And how long was he in the hospital? If there were any pipes, when were they removed? And any other, if also any kind of drug history, whether he was on any kind of medications also for this pain or otherwise also or not, sir?
Okay, I think you have elaborated quite a lot of things. Achin, go ahead.
Yes. Patient was apparently asymptomatic 3 months back when he started developing left loin pain in serious in onset, gradually progressive, dull aching type, continuous in nature, relieved by taking medication, non-radiating type, no specific aggravating factor, no positional variation.
Yeah, go ahead.
No history of nausea, vomiting, no history of any fever, burning, maturation, no history of lower urinary tract symptoms, no history of lithuria, hematuria, no issue of trauma, no issue of previous similar complaints, no issue of any facial puffiness, lower limb edema, exertional dyspnea, no issue of weight loss.
Finish the full history now.
Past history, no issue of any diabetes mellitus, hypertension, ischemic heart disease, no issue of Cox contact, no issue of any previous surgeries. Family history, no issue of any similar complaints in family, no issue of Cox in family. Diet is mixed, appetite adequate, bowel regular, sleep is undisturbed, habits, non-smoker, non-tobacco chewer, non-alcoholic.
Yeah. So just this is a history. From history, can you make out anything? As
So
a
based on what,
urologist, when you are sitting in your clinic and the patient comes, what are the differential diagnoses that
yes,
minimum that will come in your mind?
yes, sir. So the patient is having left flank pain. So I would like to give a differential related to the genitourinary tract and associated with the GI tract or muscle pain. So genitourinary tract, the differential could be
Mainly
stone dis.
let us talk about now, the every time we have discuss about a history, so we want
Yes.
to go more towards the discussion. So you tell us what are the differential diagnoses in the urinary system?
Urinary system. So stone disease, upper urinary tract stone or renal PUJ stone, cystic disease of the kidney, infections of the kidney, could be pyelonephritis or any pyelonephritis, chronic pyelonephritis or chronic pyelonephritis or acute on chronic pyelonephritis, and any other differential could also be a tumor, but
Ojas,
less likely given the age group, sir.
Ojas, there is only
Yes,
a
sir.
pain. So priority wise, what are the differential diagnoses that will come in your mind?
So stone
You are
disease
talking
and
of, oh,
yes,
if
sir.
you are talking of pyelonephritis, there is no history of any fever,
Fever.
no other
Yes, sir.
problem.
So the stone disease and cystic disease will be a primary differential in the genitourinary tract.
Congenital disorder,
Uh,
Stone disease. Stone disease would be the first differential. Secondly, sir, it can be an infected cyst, sir. It can be PUJ obstruction also, sir, which may be causing this kind of pain. And sir, other than that, this can be some infectious pathology or infectious or inflammatory pathology also, sir. And lastly, sir, tuberculosis, sir. It can mimic anything, sir.
Better at
you want to
this
comment on
stage,
this?
you should be better at this stage, Abhishek, not to comment on tuberculosis because he doesn't have any no lower tract
Yes.
symptoms, no any history of pulmonary pox in the past.
Right, sir.
So suggestive कुछ भी नहीं है तो better to avoid that. Sequence wise, stone disease, cystic disease, it may be simple cyst, complex cyst, or polycystic kidney or PUJ obstruction. These are the 2-3 diagnoses हो सकता है. Picture again, Imtiaz is telling ureteric picture, so it is again rare. And in spite of having some concrete proof, clinically ureteric diagnosis of ureteric picture is not easy because it needs proof. Without that, you cannot diagnose clinically ureteric picture. It may be any benign or malignant obstruction of the upper tract, that is ureter or PUJ. So in terms of PUJ obstruction or some malignancy हो सकता है क्योंकि malignancy या फिर malignancy in the ureter that may be blocking and causing the pain. It can be placed in fourth, fifth diagnosis. So first diagnosis, stone disease. Second diagnosis, cystic oblique PUJ, or third, any benign or malignant of upper tract obstruction. So without just by one complaint, you cannot conclude to one diagnosis. It needs further evaluation in terms of multiple investigations as per the need. We will go ahead with the investigation ऐसा बोलना चाहिए.
Right, sir.
Yeah. So I think the commonest thing in young age, one, we must take the like stone disease, calculus disease, congenital like a PU junction, and as you said, cystic disease, and the last will be either malignancy or tuberculosis. These are, I think, 5 things we must keep in our mind. Yeah. Okay. So now, Abhishek, what do you want to do?
Sir, next I want to examine this patient, sir. I would like to do a general examination and a systemic and an abdominal examination and PR examination with genital examination, sir.
So what are the important things you want to look at?
Sir, in general examination, I don't think I'll find anything specific in this, sir, excepting pain. And other than that, in abdominal examination also, there other than pain in the flank region, left flank region, I don't think there'll be anything specific. In genital examination also, sir, since he's only complaining of pain, it might be non-suggestive. And yes, sir.
So just what are the positive findings you are thinking of, or you are looking for?
So in the general examination, as he mentioned, we would like to look for so in this patient related to his history, only the flank pain. I would general examination would include only the actually the main would be the per abdomen examination, where I would look for the flank pain, any palpable lump, any flank tenderness, renal angle tenderness, that I will look for, and then proceed ahead with as an extension of the clinical examination would be a sonography of the abdomen plus pelvis.
Okay, fine. Achin, go ahead.
Yes, sir. Patient is conscious, cooperative, well into time, place, and person, lean, built, and well nourished. Pulse is 80 beats per minute. BP is 110 by 80. Respiratory rate is 20 cycles per minute. Afebrile, SpO2 is 98% of room air. BMI is 19 kilogram per meter square. Carnoscopy score is 100. No evidence any pyloric cyanosis, clubbing, lymphadenopathy, or edema. Head to toe and spine examination is grossly normal, sir.
Okay, fine. Go ahead.
Local examinations are inspection umbilical is centrally placed, all quadrants moving equally with respiration, no scars, sinuses, engorged veins. Palpation is no localized temperature tenderness, bladder not palpable. Percussion is tympanic not present all over the abdomen, normal liver dullness span, auscultation, normal bowel sounds present. Patient is genitalia normal, patient is circumcised, and all hernial orifices are normal.
Yeah.
And per examination, sir, no fissure, fistula, hemorrhoids, anal tone normal, prostate not enlarged, firm in consistency, smooth surface, non-tender, upper border can be reached, median surface palpable, rectal mucosa mobile, rectum empty, no blood on gloves.
Fine. So Abhishek and Ojas, what we have gathered is only that patient has got a pain,
Flank pain,
right?
yes, yes.
And no other
Yes.
positive finding. So now
Okay.
next, what you want to do?
Sir, I'd like to further investigate the patient by doing a urine routine examination and an ultrasound of the KUB region, sir.
No blood investigation?
Initially, sir, only.
At present, on the current complaints of just flank pain, there is no fever or any other specific finding in the history. I would just like to first do a ultrasonography, which will be an extension of a clinical examination to look for any further positive finding to help further in my evaluation of the patient.
So urine is not included in your examination. So you'll call patient again and again.
So urine routine microscopy and I will do a ultrasonography. So both, sir, I will do both, sir.
See the basic. See, every time we have
You both please let me know when patient of colic or pain come to your clinic or OPD of any hospital, what you people will do? You will do one urine routine, then CBC, then serum creatinine, then sonography, then CT scan. ऐसा करते हो कि कोई वन गो में कुछ प्लान है आपके पास? क्योंकि दिस पेशेंट हैड अ लेफ्ट फ्लैंक पेन, उसका रेडिएटिंग है नहीं है, कोलिक है, नॉन कोलिक है, उसके हिसाब से तुमको प्लान करना है. And what is the best gold standard investigation in terms of urinary colic or any colic related to the your first diagnosis? If your first diagnosis is stone disease, I can accept TBC, urine routine, serum creatinine, one sonography. Okay, X-ray QB. If you are going on that track, X-ray QB sonography. Okay. If you say CBC, urine routine, serum creatinine, and QB, that also okay. But अभी sonography करेंगे, फिर serum कितने बार blood निकलेगा? Is this patient is not required serum creatinine and CBC in the management? लगेगा या नहीं लगेगा?
Yes, sir.
लगेगा, yes sir.
Yes, sir, लगेगा.
बेसिक इन्वेस्टिगेशन है, उसमें ऐसा है कि it shows your maturity and your planning to the exam.
You always go for a basic investigation, and if you are suspecting some other disease which is in your mind, then you can ask for that. Like for example, you are doing for the prostate on PR, there is a hard nodule. So in that you can extend your investigation as a PSA, or you want to do MRI or something like that. But otherwise, when we don't know the diagnosis, these are the 4 or 5 basic tests every time we have said that you have to say.
Okay, sir.
Okay, Achin, go ahead.
Yes, sir. Sir, investigations, hemoglobin is 13.8, count, WBC count is 10,000, and serum creatinine is 2.52, blood urine nitrogen 62.
Yeah, it is 2.52.
Okay. Fine. Ajin, ultrasonography.
So if you have not done a serum creatinine and given analgesic to him, his creatinine will go from 2.5 to 4.5.
Yes, sir.
Yes, sir.
So that is why the basic investigation is required.
Urine routine micro shows WBC is 3 to 4 per high per feet, RBC is absent, and albuminuria +1.
Okay. Sonography, what was the report?
Culture sensitivity shows no growth. Ultrasound QB shows bilateral enlarged kidneys with multiple cysts. Right kidney largest cyst 5 by 4 centimeter. Left kidney largest cyst 3 by 3 centimeter. Right side ureter normal. Left side moderate dilatation of upper ureter with moderate hydronephrosis. And bladder capacity 350 ml. Postward 15 ml. Prostate is 20 gram.
So are you happy with this sonography report?
Unnecessary multiple cyst.
So
Any
what type of that cyst is?
Yes, sir. To characterize.
Ultrasound is definitely helpful in identifying the nature of the.
Yes, sir.
Yes, sir.
Ultrasound is better than any other investigation because identification of simple cyst is best identified in ultrasound. Internal echoes inside the cyst, septation, calcification in the wall. Obviously, CT classification is always there, but ultrasound is a basic. It means multiple cysts of size joints. Is there any compression on the pelvic system? Is there any signs and symptoms of bleeding inside the cyst? Is there any internal septa inside the cyst? So, Bosniak classification type 1, 2, 2F, 3, 4, 5. कौन सा ये पूछना चाहिए ना?
Yes, sir. I would like to know the nature.
Otherwise, this doesn't need any treatment. Because that this patient had presented with pain and sonography suggests of cyst bilaterally. So first, any clinician will think that this pain may be probably related to the some cyst. So what will cause the pain? So there may be bleeding inside the cyst. There may be infection inside the cyst. So these are the 2 common causes when there is a cyst, which causes pain. So these basic things can be judged on ultrasound. So whenever the presenter gives ultrasound report, we should ask this. Is it a simple cyst or complex? This question should be asked.
Yes, sir.
Right, sir.
Okay. So, this was the findings only in sonography because it was done in a some small place. So we had over here handwritten investigation. So now next what? Abhishek, now in which direction you are thinking?
Sir, considering his history and left kidney cyst 3.3 centimeter and associated moderate dilatation of upper ureter, there is some obstructive pathology present in the left side only, sir. It could also be some infection of the cyst also, sir, which may be causing his pain. So in this direction, I'm thinking, sir.
Abhishek, two
Yes.
things. Left hydronephrosis as a result of compression by any one of the cysts. Upper ureter का है, hydroureter है नहीं है, sonography पे exactly बोल नहीं सकते. It may be compression, it may be different pathology other than the cyst.
Yes, sir.
Inside the lumen of the ureter.
Yes, sir. Could
So
be.
up to what level that ureter is dilated, that is important.
Yes.
Anyhow, that creatinine is 2.5. The question in front of the clinician is this cyst is causing a compression? One. Number two, is there any another intraluminal or extraluminal obstruction inside the ureter which is causing the hydronephrosis? That we have to search, considering the serum creatinine 2.5. You have to ask another investigation.
Yes, sir. So the cyst, sir, is 3 by 3 centimeters. It's less likely to be causing compression on the ureter.
Not necessary. If the cyst is present in the peripelvic area or parapelvic area near the hilum, it may compress the pelvis.
Sir. Okay, sir.
So now, Abhishek, these are the findings. You are happy, or you want to do something else?
No, sir. I want to investigate the patient by doing a non-contrast CT scan, sir, of the KOB region.
Ojas, what is your idea? What do you want to plan?
So I would like to again go ahead with a non-contrast CT since the creat is high to look for what is the cause of the dilatation of the left side of the pelvic areation system. So we can see a cyst, but the nature of the cyst has not been commented on the USG. So a non-contrast CT, since there's a limitation because of high creat, we'll do a non-contrast CT KUB to look for any other pathology surrounding the ureter or also to characterize the cyst further.
Okay. Pankaj, you want to guide them something at this level?
No, I think things are moving all right, sir.
Okay. So then we should go ahead. Okay.
Yes.
Achin, show
Yes,
them.
You want me to zoom? Tell me the quadrant where to zoom.
Who wants to comment?
So this is a non-contrast CT scan, abdomen plus pelvis, showing the coronal and the axial cuts. The liver appears normal. The spleen appears enlarged. Bilateral kidneys are enlarged. Multiple cysts are seen in both the kidneys on either side. On the left side,
there is significant amount of parenchymal thinning on the left side, sir, and the whole kidney appears to be cystic, and there is a small calcification also seen, most probably in the cortex of the left kidney.
side.
And there is also associated hydroureteronephrosis of the left side, continuing at least till the distal ureter, sir.
It is still L5, upper ureter only, L5.
And what else? Are you happy with the contour of the right kidney?
No, sir.
No, sir.
It is enlarged, and sir, there is
the cysts are replacing most of the parenchyma on the right side as
yes.
well, so we can't actually appreciate the parenchyma well. And
it is only in the parenchyma.
Also,
Have you seen polycystic or multiple cysts in the kidney? CT
yes,
scan.
sir.
Yes, sir.
Does it appear like this?
Yes, sir. Right side appears like that more because there are multiple cysts replacing most of the parenchyma on the right side. Left side, there are there is mainly in the lower part there is a cyst along with the calcification adjacent to it at the lower pole.
Right side also you can see some calcification.
Right side. Yes, so that appears to be in the region of the ureter probably, or some could be some lymph nodes also in the vicinity.
So it is outside the urogenital system, correct?
Yes, sir.
So what
Yes.
else it can be? In the pelvis, if you see, it can be a phleboli, but here,
Calcified.
Calcified thing.
yes, calcified what?
Calcified
Calcified lymph node or
cell or
vein.
lymph node.
Exactly.
Lymph node or vein, yes, sir.
So what are the positive findings you are seeing in this?
Multiple cysts on either side, mainly on the right side. Left side hydrohydronephrosis till the level of the L5 lower border. Calcification in the left kidney, and also on the right side calcified lymph nodes in the vicinity of the upper ureter and along the upper part of the ureter, right side, and some splenomegaly as well.
How's the bladder?
Yes, Bolo.
Sir, the bladder appears
Bladder,
to be shrunken, but I can't make out exactly, sir.
some calcification.
It looks like a very small capacity
Yes.
bladder. At least in
Yes.
the upper left, right image in the coronal. You see, the way I would describe this is that, okay, let's look at the bladder here. So either we could say that the bladder is not full, or it could be a small capacity bladder. The bladder wall doesn't appear to be thickened. Okay. Now, you should also comment on the ureter. Doesn't this ureter look very spastic? Okay, it has become something like a straight line going from the kidney to the pelvis. So in the right kidney parenchyma is replaced by cystic lesions. There is inhomogeneous, cortex seen all around. Renal pelvis is intrarenal and spastic. Ureter is again thin and spastic, and some calcification is seen along the ureter. So this would be a very, very classical image of GU Cox. And when you are keeping a diagnosis of GU Cox, the small capacity thimble bladder would fit into this.
Yes, sir.
Abhishek, this is
Yes,
very
sir.
important. Unless and until you keep on seeing normal CT scan, normal sonography continuously, unless and until you do 100 PR, you will not realize what is abnormal. The same thing
Yes,
is
sir.
true with all these things. How many positive points Pankaj has found out? Even if you are seeing on the left hand side, are you seeing the typical hydronephrosis?
No, sir.
Are you seeing that there is a dilated pelvis and then all the calyces are also dilated? Are you able to see normal
Yes, sir.
configuration?
Can't make out, sir.
Then even on the right hand side, it is totally, distorted kidney. So many things are positive findings are there. So as Maheshwari said, once you say all these things, you can affirmatively you can say, okay, sir, I am thinking in terms of GU Cox after this CT scan study. So now next what, Abhishek?
Yes, sir. Sir, with the working diagnosis of GU Cox in my mind, I'd like to confirm my diagnosis, sir. I'll do a urine for gene expert, and culture for AFB, sir. And also a chest X-ray along with it, sir, too.
Abhishek, you agree with him?
Sir, this patient has sterile pyuria because urine culture is no growth and there are pus cells. And based on the CT scan findings,
How many pus cells? How many pus cells? How many pus cells are there?
4 pus cells. I think
Achin,
3 to 4 pulses per
4
hyper.
pus cells. Yes, sir.
okay.
why you're saying it is a sterile pyuria?
Okay. But there are positive findings on the imaging, sir. So I would like to evaluate further by doing urine for AFB smear, urine for CVNAT, urine for culture, TB culture, and urine for cytology as well, sir.
Okay. Achin, just show them what was done.
Sir, should I read
It
out
is
the report?
okay, you go ahead. I think Maheshwari has said more than what this CT report has said.
Yes, sir.
सर ज्यादा तो नहीं देख लिया
After
Just
this,
show. Yeah.
patient underwent cystoscopy with bladder biopsy with bilateral PCN
No,
insertion.
no, no. Before that, we have done that urine report, na?
Abhishek,
Yes, sir.
2 questions. One is,
Yeah.
how much is the capacity of bladder free-wide capacity on sonography? That is one
350.
thing.
350.
350. 350, 250.
350, sir.
350 mm. 350 mm.
And one film they have just yes, this CT film. Please go for CT film. अभी जो दिखाया था bladder दिख रहा था. CT film में bladder दिख रहा था.
Yes.
Yeah. तो zoom it.
Left hand side, lower down, left hand side.
So, नहीं ठीक है सर. जो अभी जो दिखा रहा था वही है. तो longitudinal film में दिख रहा था. उसमें क्या ureter का hydronephrosis कहाँ तक है पता चलेगा. Yes. So if you zoom it, there is a left hydroureteronephrosis right just proximal to the bladder. That is up to the lower ureter. As sir said, it is a right ureter is spastic, non-dilated, distorted right kidney with multiple cysts, calcification in the retroperitoneum, maybe lymph node calcification along the left mesentery of the colon and the left unequivocal or unsymmetrical hydronephrosis with the secondary kinks in the ureter.
Ureter.
Yes, bladder is not that much symbol considering this picture and sonography finding. But obviously, it is a all the picture on both sides suggest genitourinary tuberculosis. So, how will you confirm this tuberculosis?
Sir, urine for gene expert and culture for AFB, sir.
Is urine for gene expert or urine for DNA TB PCR is sufficient, or you have to do for culture?
Sir, urine for gene expert is not very specific, sir, because it can show previous inspection also, sir. But urine for AFB culture is the gold standard.
How much time culture will require?
Culture will require 6 weeks, sir.
Any other short, fastest way to diagnose?
CVNAT, cartridge-based nucleic acid amplification test.
Nuclear acid
Gene
amplification.
expert.
So, what routinely you are doing at your place? You are going for both PCR as well as PCR study as well as culture, or only PCR if negative go for culture? If clinically suspicious of tuberculosis or radiologically suspicious of tuberculosis.
Only PCR, sir. It will give a result early, sir.
So it will within a short period, near about within 24 hours, urine for DNA oblique RNA TB PCR will give result within a 24 hours. आज भेज दिया तो कल तक report मिल जाता.
Yes.
If it is negative, and if you are suspecting clinically and radiologically, then culture will take 6 to 8 weeks. It usually it has a sensitivity of 80 to 90%, and culture is definitely a gold standard. Okay, what are the other way of diagnosing the tuberculosis?
So we will also do a chest X-ray and sputum. This is as part of the guidelines of the RNTCP that if you are suspecting GUTB, we will also do a chest X-ray and the
How chest
sputum if possible.
X-ray? How chest X-ray will help in diagnosing the tuberculosis? GU tuberculosis.
So any past history of pulmonary cause, though the patient doesn't have a history, we can see a calcified focus or any previous calcified Gons complex.
What are the incidences of past history or old healed cocks on chest X-ray, and what is the incidence of active tuberculosis in the chest?
Sir, after pulmonary TB, it takes 10 to 15 years for GUTB to manifest, sir.
And that is true. But if you are doing a chest X-ray, and what are the chances of getting the active tuberculosis in chest X-ray, and what are the chances of getting old healed cocks in the chest X-ray? Because radiology suggests of GU cock.
So old healed, sir, in case of GU-COX, old healed lesion will be more common, sir.
50 to 75%.
50 to 70%.
Old healed cock,
Okay,
and
sir.
5 to 10% patient may have
10%
active tuberculosis.
Active tuberculosis, yes, sir.
And what you are told already, it is 16 to 25 years required for old pulmonary tuberculosis to generate tuberculosis. Pulmonary tuberculosis healed, treated, then what are the time required for reactivation of pulmonary tuberculosis? 4 to 8 years.
Okay. Okay, sir.
48
Okay,
years.
so chest X-ray और क्या बोला आपने?
So, the patient doesn't have any sputum, but chest X-ray mainly, sir. Chest X-ray. Sputum is also, but he doesn't have cough or any symptoms, so less likely to have it for investigation purpose. So we just do a chest X-ray and see if anything is missed out in the history part.
Okay. Just now you are told sterile pyuria. What are the causes of sterile pyuria?
So the causes of sterile pyuria could be infectious conditions, which could include tuberculosis, viral infections, parasitic, chlamydia trachomatis, then inflammatory causes, which could include stone disease, then chemical cystitis, then we could have
Which stone you have sterile pyuria?
sir, lower ureteric stone or along with so both vesical calculus with lower ureteric stone. Lower ureteric stone, sir. Lower ureteric.
Why you are so specific about lower ureteric?
Oh, sir, any stone, actually, sir, any stones. Any stones could have sterile pyuria. And other causes also, yes, sir.
Could be a feature more of non-obstructing stones.
Okay, sir.
Types of stone. What are the and non-infected stones?
Yes.
Non-infected stones, yes, sir. Sir, and it could be also from abnormal contamination from the urethra, or from the, in case of a female, from the cervix or the perineal region.
Incompletely treated UTI, sterile pyuria can occur. It can occur with foreign body also.
So you can add acute tubulointerstitial disorder, you can add acute nephritis, you can add mycoplasma infection, and the chlamydia trachomatis, tuberculosis, prostatitis, have sterile pyuria. Okay.
Yes, sir.
Chest X-ray दिखा दो.
Chest X-ray, sir, was not done. CT was done, sir.
CT chest?
CT chest. That's normal, sir. Fibronodular opacities in both upper lobes. Sequelae of old infective etiology. No active.
It is old infective etiology. But it is in the upper lobe.
In spite of
Yes.
going for CT abdomen, if someone has done a X-ray abdomen, so what are the probable findings you can have in X-ray abdomen standing or X-ray in same patient, in this patient?
So calcifications in the area of the kidneys you can look for, or along the ureter. That one. Second,
This is CT-QB report.
Calcified lymph nodes may be seen on
Calcified lymph nodes could be seen. Calcified lymph nodes and calcification in the area of the kidneys, in the area of the kidneys, basically, sir. In this patient, we could be able to see.
So calcification in the paravertebral area, calcification in the lymph node, calcification in the mesenteric area,
also,
calcification in the adrenal gland, calcification size of the kidney can be judged down abdomen standing. So these are, and then due calcification up to in 50% of the due calcification and extra genital calcification, extra urinary calcification. Both calcification can be diagnosed on X-ray abdomen scan. Okay. Then in this patient, is any role of MR urography? Suppose I 2.5 creatinine, I don't, in spite of going for CT, CT QAB, can it be possible to have MR urography for diagnosis of problem in this patient? Left hydronephrosis, ultrasonography, multiple cysts. So MR urography, 2.5 creatinine, MR urography or NCCT?
Sir, MR urography, sir, MR urography will not give any extra detail in this case because no, sir. Other than sir, it will help to characterize the cysts better, sir. MR urography, and sir,
if my first diagnosis is ultrasound urolithiasis, then better to go for NCCT.
CT. Yes.
But this patient had left hydronephrosis and multiple. So intraluminal obstruction is best diagnosed by MRU than the NCCT. One. Another thing is characterization of the cyst is again better with MRU than MRI than the NCCT. So MR urography is another alternative investigation anyone have compared to so NCCT. Why you have preferred NCCT? Because your first diagnosis is urolithiasis and patient presented with polyp. So how many percentage of the patient of genitourinary tuberculosis presented with polyp? So what is the common presentation of genitourinary?
common presentation of genitourinary tuberculosis includes dull aching flank pain associated with evening rise of temperature and weight loss of weight and loss of appetite. And it may or may not be associated with sterile pyuria. Occasionally, hematuria or microhematuria may also be present.
So also and storage symptoms of the bladder.
Storage symptoms of the bladder.
Could be present.
For that, you must know how the urinary system is involved in the tuberculosis.
Yes, sir.
So if you know that, then you will definitely able to tell the clinical prediction. So it is either entry from up or entry from below.
Yes, sir.
Okay. Or rarely as a multi-organ infection, that is miliary tuberculosis.
Yes, sir.
Or sometimes intravesical BC. These
Yes,
are rare causes.
Yes, sir.
So if it is entering from up, then it has to enter from cortex to medulla to rupture in the PCS, then involvement of ureter, then lower ureter is more common because stagnation is more, and then bladder.
Right.
Yes, sir.
Or it has to go from good soil is from epidermis, prostate, the bladder and bladder. So the commonest presentation in case of the genitourinary tuberculosis is clinical symptomatology, the storage prominent symptom. Approximately 75% of the patient present with symptomatic UTI or gross or microscopic hematuria. And storage LUTs, that is dysuria and severe
Frequency.
Storage prominent symptom. Female may menstrual irregularities, then nocturia, then 10% of the patient presented with renal polyp. Then sinus over the anterior wall of the scrotum and sinus over the posterior wall of scrotum. My important, I usually ask in the exam, what is your difference? So it's sinus over the scrotum, if it is involved. then bladder symptoms already I told. Then constitutional symptoms of the tuberculosis: fever, weight loss, night sweat, anorexia. Then symptoms of the renal failure. If it involves the urethra or it involves the bladder, or if it involves the thimble bladder, high pressure bladder, back pressure changes, kidney fail, bilateral ureteric blockage, bilateral ureteric stricture, then back pressure changes and kidney fail. So signs of the renal failure. Then associated renal artery stenosis secondary to the tuberculosis and hypertension, and superadded infection, that is sepsis. Then stone disease. Again, stone disease is more common in tuberculosis. Approximately 7 to 15% of the patients presented with stone disease. So these are the clinical presentation of the tuberculosis, and better characterization of the involvement of the pelvic system is with either a conventional IVP replaced nowadays by CT urography, and now in this patient MR urography. Because callosial distortions, then various type, n number of signs are there, net about 10 to 20 signs. In ureter, 5-6 signs. In PCS, 5-6 signs. In bladder, 4-4 signs. So these all can be characterized better in MR urography in this particular case. Or creatinine is normal, then CT urography. So an examiner can ask you what is the signs, various signs, what is the podal signs, what is the tear sign, what is meant by ring sign, or what is meant by beading of the ureter, what is the thimble ureter, what is the golf hole ureter, timber bladder, golf hole ureter. ये सब चीजें अगर जितना पूछने के लिए कोई आंसर देने का जरूरी नहीं, तो ये पूछ सकते हैं. ये थोड़ा सब चीजें देख लो. एटलीस्ट दो चार साइंस पता रहना चाहिए. Okay, go ahead.
Sachin, show them what positive finding about the urine we have done.
Yes, sir.
Yeah.
Positive.
TB PCR with hybridization, sample is urine, result TB PCR is positive.
So now, Ojas, now what is your diagnosis?
Sir, based on the current history and the examination findings, the patient has two major criteria for the diagnosis of genital tuberculosis, that is urine AFB positive and this thing, and histopathology is also shown. Histopathology, so basically has one major criteria which is sorted. I think, sir, I saw in the histopathology that is also showing. Can I see the histopathology report once?
Actually, after patient came with
I have
CT
seen.
scan,
No.
patient
Ojas.
went-
Yes, sir. Yes, sir. Yes,
Please
sir.
understand. These are the things because it is not streamlined. You are able to see all these things. We are
Okay.
going to ask you question. Now you have reached up to this
My
level.
question
What
to
is your
you is
diagnosis?
why
Give me a full diagnosis.
Sir, this is a case of genital tuberculosis with involvement of the bilateral kidneys, and we can see there is a left upper ureteric stricture and distortion of both the callosial systems on both sides.
With
The small capacity
what is the creatinine?
with the
देखो भाई
uropathy.
लेफ्ट यूरेटर तो लोअर यूरेटर तक डायलेटेड था. Bilateral renal cyst with left hydroureteronephrosis up to lower ureter with deranged renal function with, if you want to say, small capacity bladder, small capacity.
So yeah, bladder is 350 ml capacity. Bladder looks to be normal capacity.
अगर तुमको लगता है तो बोलो, नहीं लगता है तो
yes, sir.
दोनों में से कौन सा भी. अभी इसमें
Yes,
तुम
sir.
क्राइटेरिया का जब बात चल रहा है तो यू शुड नो द व्हाट इज मेजर क्राइटेरिया, व्हाट इज द माइनर क्राइटेरिया. इसमें मेरा फर्स्ट क्वेश्चन है कि व्हाई यू वांट टू गो डायरेक्टली फॉर बायोप्सी, बिकॉज़ योर पीसीआर इज पॉजिटिव. व्हाट इज द नीड ऑफ बायोप्सी, डूइंग द बायोप्सी?
So no need of biopsy here. TB PCR is positive in not.
Then
Yes,
you
sir.
are used, just now you told me biopsy is also suggested.
No,
So
sir. Sorry.
examiner
Actually,
has not asked you
yes, sir.
to
Yes,
go
sir.
for
Yes, sir.
biopsy. You are also not told कि biopsy is required. So उन्होंने दिखाया तो तुमने क्यों पकड़ा उसको? So what are the positive findings in this patient till now? The radiological changes IVP is one of the minor criteria. So radiological changes on NCCT QEB that can be considered as
Minor.
Minor criteria. Minor criteria.
minor criteria. Another one major criteria, positive
PCR
PCR.
positive.
Positive
PCR
TB
positive है
PCR.
ना?
Yes,
है
Yes, sir.
ना?
TB
Positive
PCR.
PCR है ना?
Yes, sir.
So one
Yes, sir.
major and
And
one minor. अभी
one
और एक
minor.
minor चाहिए अगर तुमको diagnosis करना है तो.
Yes, sir.
तो one major and two minor चाहिए. और कौन
Yes,
सा
sir.
minor है क्या देखो इसमें.
There is no hematuria. There is sir. There is on the HRCT there is a the lower nodule in the left lower lobe there is opacification. So that is also suggestive of
Pulmonary
another
changes
minor.
of old hill cox sound
Middle cox.
HRCT. That is another
Yes, sir.
minor criteria.
Minor
So
criteria.
one major and two minor.
It will fulfill your requirement.
Yes, sir.
One major
and two
plus
minor.
two minor. So your diagnosis of GUTB is fit now. With
Yes,
renal
sir.
failure with bilateral simple renal system on right side. Agreed.
Yes, sir.
So what are the other major criteria? Now
so
if you want to go for another major criteria than granulomatous lesion on HP, so you have to go for biopsy.
Biopsy.
When biopsy is required, your clinical and radiological diagnosis of tuberculosis, and in spite of doing laboratory workup, your diagnosis is not confirmed. As a lost biopsy, doing a biopsy in a tuberculous bladder is not easy job.
Yes, sir.
So granulomatous lesion on HP is another major criteria. AB positive is another
Yes,
major
sir.
criteria. And minor criteria you already told. One is missing, that is increased ESR
And hematuria.
and
That
hematuria.
is not there in this patient. Yes, sir.
So one major and two minor criteria is already there inside the patient. Now how will you proceed?
So before that, Gite sir, I want to ask them, suppose the patient comes with hematuria, patient has got lots of lower tract symptoms. Okay, you are suspecting tuberculosis, you have done gene expert or RT-PCR, whatever it is positive, and there is again chest is showing fibrosis. So you have got one major and two minor criteria. Now in this patient, you will like to do IVP if the creatinine is normal, or you will like to do CT IVP. So which will be better, or which gives more information?
Sir, CT IVP will be better, sir, in case of if this patient presents with hematuria. Sir, we'll be able to characterize what
No,
is
you
the...
diagnose this patient has got GU-COX.
Sir, with the CT urography, we'll be able to rule out any other diagnosis which may be causing hematuria, sir. Bladder mass or anything, any lesion in the kidney which may be causing hematuria, sir. So that way, CT IVP will give us more information than normal IVP.
So what are the advantages of normal IVP? And what are the findings you can see in IVP?
Sir, findings that we can see in the IVP is starting from renal shadows, sir. We can see uptake of contrast, which will give us a hint about the renal function. We'll be able to see any filling defect in the pelvic calyceal system, sir. We'll be able to see the character of the ureter, sir. If there is any filling defect or a cutoff of contrast, we'll be able to see, sir. Then moving on to the bladder, sir, we'll be able to see the approximate capacity of the bladder, sir, and any filling defect in the bladder, any on
in tuberculosis. Ojas, in tuberculosis, what are the things you'll see in IVP?
So in tuberculosis in IVP, in the scout film, I would like to look for calcification in the region of the kidneys, calcification along the ureters, calcification in the paravertebral region, calcification in the region of the bladder. That is in the scout film. In the further films, in the further series of the IVP, I would like to look for the uptake, whether there is uptake on both sides. So if there is no uptake on one side, that could indicate, and in the further film also, that could indicate a non-functioning kidney, which is that is one. Then we could look for any other filling defects. We could look for the distortion of any distortion of the calyceal system, infundibular stenosis, any ureter dilatation, then the capacity of the bladder. Yes, sir. And also we look, yes, sir, capacity of the bladder, and yes, sir.
So basically, sir, on TB, on IVP, sir, from kidneys starting, we'll be able to see the size of the kidney enlarged or not, or is it a small sized kidney? And as in case of advanced TB, we'll be able to see calcifications in the kidney on the scout film, sir. we'll be able to see, sir, we'll be able to see the condition of the calyces, sir. If there is a cutoff from the calyx, if there is any kind of phantom calyx, if there is infundibular stenosis, sir.
So, Abhishek, in
Yes.
spite of telling in detail, let examiner ask. What you should tell? You should tell. If serum creatinine is normal, I will go for CTIP because diagnosis of renal and extrarenal spread of the tuberculosis best diagnosed in the city of the involvement of ureter is best diagnosed and associated spinal and solid organ involvement is best diagnosed. So that's why I want to go for CTIP. Let examiner ask you what are the findings, cell involvement, what are the findings on CT. So conventional IUP, why conventional IUP is replaced by CTIP nowadays, this is the reason. Because conventional IUP is just showing the cell involvement and intraluminal thing, that's all.
Yes.
Why CTIP nowadays? Renal extrarenal involvement, length of the ureteric involvement, associated spinal and solid organ involvement, ये सिर्फ CT पे ही मिलता है.
Yes.
Then if examiner asks you what are the signs seen on CTIP or conventional IUP in kidney, then you will tell a number of signs whatever you know.
Fine. Okay. So you understood how to answer.
Yes.
Now, these are the findings. So next, what you want to do, Abhishek?
Sir, there appears to be some kind of obstruction, sir, which is causing a raise in creat. So, sir, I would like to relieve the obstruction by doing there is a distal, there appears to be obstruction in the distal ureter on the left side also, sir. So I'd proceed by doing a DJ stenting and DJ stenting on the left side and start the patient on AKT, sir.
So right side, you don't want to do anything. Why the creatinine is high? Only because of one kidney?
So bilateral PCN or bilateral antegrade DJ stenting would be first preferred in this patient. Both sides are affected, as we can see in the system, and the creat is also high. So we will go with bilateral either PCN and then antegrade stenting preferably. Retrograde if possible or antegrade DJ stenting, sir.
So,
And then
Achin, first what we did, just tell them.
Sir, one question. Indication of decompression on right side.
Yeah.
What you want to decompress? What you want to decompress by putting a PCN or DJ? Because whole of the ureter is fibrotic. Okay. There is a total internal filling. Whole of the kidney majoritarily replaced by the kidney. So what you want to decompress? By placing the PCN or DJ, what changes you expect on right side? Left side I accept. So why raised in creatinine if one kidney is normal? So that kidney is not normal. Pathology is in both the kidneys, but different pathology. A different way of presentation of same pathology. One is may not be relieved by doing the decompression, and another definitely will be relieved by doing the decompression. So here on right side, if there is no hydronephrosis or no signs of obstruction on right side, then what you will gain by placing the PCN and doing a PCN in a tuberculous non-hydronephrotic kidney, how easy it? First is why you want to place, another is how difficult or how easy. That is on for right side. For left side.
Ojas and
Yes, yes.
Abhishek, whatever you see, that doesn't mean that is God's word. Okay?
yes, sir.
Right? What is right for that particular patient, that is. So as Dr. Venkat Gite is asking you that on the right hand side, why you want to put a double J stent? Is it going to help you? Is there any hydropelvis? I mean,
sir.
there is
No,
a
sir.
hydronephrosis. Is there any? So by DJ stenting, what you are going to achieve? Do you think that right kidney, if you are thinking that right kidney might be functioning, some of its parenchyma is thick and it might be functioning. With that idea, you can think of doing PCN. But even if you do PCN, do you think you are able to, because all the calyces may not be connected to each other in this case. So will you be able to drain all the calyces in this case?
On the right side, no.
Right side, no, sir.
Yeah. So on the right hand side, it is useless actually to do anything. But
some,
still,
some Yashir is telling there is VOR on right side. How he diagnosed VOR by NCT?
CT. Yes, sir. It requires MCUG.
but
Look,
still,
answer here is I will do a cystoscopy, assess the bladder capacity, then I will do a left RGP, assess for the height and length of the picture, and try to decompress that particular obstruction by placing the DJ. Suppose DJ is not good, then I will consider for
PCN.
PCN. So this is what I will do at my. If there is a change of opinion, पंकज सर को भी पूछ लो सर एक बार ये केस में क्या है कि चेंज हो सकता है कुछ.
yeah. See, Abhishek and Ojas, we are going to tell you what has been done, but
Yes,
that
sir.
doesn't mean that it is the right thing which we have done. Okay.
Yes, sir.
So
Sir, I
patient
wanted to say
underwent
something.
cystoscopy. Maheshwari. Yes, Hiren Sodha is also there.
Sir, I wanted to say something. Sorry,
Yeah,
I
please.
was unable to mute myself all this time.
Yeah.
So what I was seeing, what Gite sir told you was so apt that why CT and why not IVP. And I saw both of you answering, and what I noticed it, you're saying that, okay, I saw calcification there, I saw this there, I saw that there. But that one sentence should have come from you is that, sir, I want to do CT IVP to see the sequelae of the disease, to stage the disease. At this stage,
Yes,
when the patient has come in front of you, you want to know what is going on and what you are going to salvage and what you are going to treat. That is
Yes,
why
sir.
Gite sir is telling now what is the purpose of putting this, saying that right kidney I will do DJ stenting and whatever. Creatinine is high, you have to save the normal kidney and stage the disease and then treat accordingly.
Yes,
So
sir.
that is the answer that should have come. You want to see the sequelae of the disease. You want to see at what stage it is, what is the extent of involvement. It is only genitourinary or it is also extra genitourinary. And now what you are going to offer treatment to the patient and how you are going to make the creatinine normal and what reconstruction you want to do.
Right, sir.
Yes, sir.
Right. So now this is again, this is what has been done, but that doesn't mean that whatever has been done is required. Fine. So patient underwent cystoscopy with bladder biopsy with bilateral PCN insertion in a government hospital. The operative findings are as below. The urethra is pale, smooth, prostate normal. Bladder capacity was approximately 350 ml with a pale mucosa. Bilateral ureteric orifices were appearing normal. But on the both the sides, glide wire cannot be or could not be passed beyond lower one third of the ureter. In the right side, so it was very difficult to even identify the ureteric orifices. And there were multiple superficial hemorrhages, and once we deflated it, it was lots of
Everything is red.
hemorrhagic fluid was there. So hence bladder biopsy was taken from posterior wall and bilateral ultrasonography guided PCN insertion was done. So now what do you expect, Abhishek? Bilateral PCN is done. What you are expecting?
I'm expecting the creat to come down, sir.
What will happen to right PCN and what will happen to the left PCN?
Sir, first of all, left PCN will start draining and the creat should come down. Right PCN, I'm not sure, sir, because anyways the kidney was, sir, right PCN, I'm not very sure, sir, but left PCN would drain and the creat would come down, sir. That is my assumption, sir.
Ojas, what will be your take on?
Yes, sir. So, right, I'm not very sure about the function. The left side, the output should be on the higher side. We can follow it up with USG to look for this whether how is the hydronephrosis settling down, and the creat would come down to a new nadir level, depending on how much function is left in the left kidney.
And
So,
sir, once
Ojas,
the yes, sir.
Ojas,
Yes, sir.
you suppose this patient had come to you Will you do PCN on the right hand side?
I will do it on the left side only, sir. Right side, even identifying the calluses would be difficult because of the cyst. So multiple cysts are there, and so I would not do on the right hand side. Mainly on the left hand side, and observe how is the hydroneutral nephrosis settling down. And then when the create comes down to a new nadir level, then I would evaluate whether the right kidney would help.
See, I'll tell you.
Yes, sir.
Sometimes even the CT scan and other things may be little deceptive. Okay.
Okay.
And that is why many a times our gut feeling says that even if the left side is showing, okay, in this case that it is a better functioning kidney, we always try to put the bilateral digestion because the creatinine is high, and we try to put bilateral PCI. But as Dr. Gite said, it is not required. Okay, so in exam
Yes.
you can be very
So
affirmative. You can say,
in
okay,
this
right side I am
particular-
not finding any salvable, missing any tissue or any connecting calluses. So it will be fruitless to do PCN on the right hand side. So instead of that, what else you will find out?
Sir, then once
it-
when the
Can
create
you do
comes,
something
once-
side?
once when the create comes down, sir, I'll do a nuclear scan too for a baseline.
Why you want to wait for creatinine to come down?
Sir, nuclear scan usually the create should be normalized before doing a nuclear scan, sir.
Are you sure? Ojas?
No, sir. In this case, because the patient has come to us for the flank pain, and then we have discovered a creat which is high. So first, I like to settle the patient for that, and then consider further evaluation based on this. And we have also got positive TB PCR. So we are considering on the lines of starting probably AKT for the patient. So we will also first have to normalize the creat levels and then proceed, because the other management would be later on. Like when the nuclear scan will be for the functioning of the other kidney, but that will be later on. We have got a positive TB PCR, so we like to get the creat down and start the patient on AKT. So that.
Ojas and Abhishek both. Here,
Yes, sir.
issue is renal failure. Issue is
Yes.
left hydronephrosis. So when you entered inside the bladder, you may see Golgi ureter, you may see multiple tubercles around the ureteric opening. You may see mucosal ulceration. You may see after removal of the just decompression, first decompression, everything is red. That is period. And nothing. So, if you want to place a digestion on right side also, go for one RGP. See what is the lumen of ureter, what is the luminal narrowing, how much is the length of narrowing, is there any hydronephrosis on RGP? If that anything suggests you that by placing or doing the decompression, it will going to help do it. If nothing is there, nothing is going, don't touch that side, go for opposite side, go for again RGP. RGP will assess the length of ureter, RGP will in cavitation inside the kidney, and hydronephrosis, amount of hydronephrosis, decompress that side, wait till
Wait till creatinine
the
comes
nadir
to the nadir
creatinine
level.
level. Now, doing in a decompress is better. So, baseline creatinine level, decompressed hydronephrosis, getting a real amount of function of that particular kidney is more in a decompressed system. Suppose, forget the tuberculosis. Suppose it is a PUJ. Okay. So why we are doing a pre-operative DTP scan? Because it is the baseline. Measure a number of times it will happen. After doing a pyeloplasty, pre-pyeloplasty 36 ml GFR, post-pyeloplasty 25 ml GFR. Because background activity can be counted more. And the purpose of doing in PUJ is another is medical legal, baseline function, comparison, follow-up, that are the number of it. Here, there is a block in the system. So first is to remove the block. Now, after removal of the block, GTP scan or before removal of the block? Here, after removal of the block. Because
Yes, sir.
system is blocked and it is causing the renal.
Yes, sir.
And whatever the benefit of doing a decompression you will get, that will help in planning further management of the disease encountered during the whatever the disease you encountered during the investigation, like for example, urethritis. So, resistant go for anti-tuberculosis treatment after nodule level formation and anti-tuberculosis treatment का induction course होने के बाद में आपको कुछ करना है उसके लिए तो वो भी कुछ कर सकते हैं.
Fine.
So this is the sequence of management in tuberculosis.
So in this case, post-operatively, right PCN was draining only 50 ml and left PCNL about 2 liters. Okay. So now looking at this, Abhishek, what would you like to do?
Sir, I'd start the patient on anti-tuberculosis treatment now, sir.
Okay. Right hand side is not draining. Suppose forget about this patient, it is not appearing a functioning kidney. But otherwise, if you have done a PCN and like bilateral PCN, and one side is draining very well and another side is not draining. So now what you like to do? So what are the causes of decreased output from nephrostomy?
Sir, the most common cause is blocked nephrostomy. Second cause is sir, nephrostomy not in the collecting system. Sir, third cause may be non-functioning kidney. Fourth cause, yes, sir, these are the most common causes.
Most common cause. So what do you like to do in that case?
Sir, assess the function
One
of the.
Yes, Ojas, what do you
One
want
more
to say?
cause I will tell Abhishek.
Pardon?
Abhishek, one more cause. If this is a patient of tuberculosis, one more cause can be to place the patient in one particular calyx, and if patient that kidney has a multiple infundibular narrowing, it will drain only that calyx. So, as per the RGP finding, if there are narrowing inside the infundibulum, you may have to place more than one PCN.
Gita sir, can you please
If you
repeat?
place
Your voice
only
is
one
cracking.
PCN, okay. In a tuber, are you able to hear me?
Yes, sir.
Yes, sir. Yes, sir. Now we can hear you.
In a tuberculosis, there are chances of infundibular narrowing.
Yes,
Right.
sir.
Okay. So, 3 calyx, 3 infundibular narrowing. If you place the PCN in one calyx, it will drain only that calyx.
Yes, sir.
Okay, then that will help only 25%. That is 1/3 of 3 is 1/3. So what about rest? So we have to place the multiple pieces as per the
Yes.
requirement.
Yes.
So for that, you have to go for RGP. Then you will see which are the calyxes communicating with the pelvis, which are the calyxes not communicating with the pelvis. Selective calycectasis. One calyx is only hydronephrotic. So another calyxes are normal. So all the calyxes are hydronephrotic, but pelvis is no hydropelvis. In such particular situation, you have to place a multiple piece
Right.
to preserve the function of the kidney.
Okay, sir.
Yes, sir.
Go ahead. What you are discussing, please go ahead.
Okay, so now Abhishek, let us go ahead. So now if it is not draining, so will you like to do PCN? I will ask you a direct question. So what are the advantages of PCN? I mean nephrostogram.
Sir, antegrade evaluation of the collecting system. Antegrade evaluation of collecting system and characterize if there is any kind of stricture, sir. Assessing the proximal extent of the stricture, sir.
Yes.
And
So first of all, you want to find out whether you are properly in that system or not.
in the system or not.
Then it will show you all the connecting calyces.
Yes, sir.
right?
Anatomical characterization can be
Yes.
done, sir.
And it will show you the upper part of the stricture, correct?
Right, sir. Upper part of the stick, any filling defect, if it's there,
Correct.
in a stone or mass or whatever, sir.
Yeah.
So that will be able to
Yeah.
characterize.
So I will just show you what Achit, just show them. Yeah. See, we did the bilateral PCN. As you can see, right hand side, it is a totally distorted. Left hand side, at least you can see some calloused system. Achit, show them the second one,
Which one, sir?
the proper one, which was showing. Yeah.
This is
Okay.
post master commission.
Yes, this
Fine.
is-
Okay, comment.
so right side.
Sir, this is sir,
Left side, only the lower callus, one callus is visualized, and the other callus is not at all visualized. So there is probably infundibular stenosis probably on the right hand side. Left side, there is gross dilatation of all the calluses with a kink at the level of the upper ureter, and the whole ureter is dilated, and all the calluses are dilated.
Are there some calluses have got the infundibulum stenosis?
Some of them, yes, sir. Yes, sir. Some of them have, but not complete narrowing. Not complete narrowing, but there is infundibular stenosis.
Even
Yes,
it is the distorted. Some
it's
calluses.
distorted. Yes, sir.
Yeah.
Yes, all the calluses look to be distorted. Yes, sir. All the calluses are distorted. There is infundibular stenosis, but not complete narrowing. There is kink, but there is kink at the level of the upper ureter at L3 level, and the whole ureter is dilated in the entire course till the mid lower ureter, and there is no any other filling defect. There is kidney
fine.
also appear. Yes, sir.
So now we have got Dr. Kanishka Davda with us. Okay.
Yes, sir.
One second, I'll just see. So he is an infectious disease doctor, and he can just tell us about the medical management. So now we want to go on a medical management, correct? Yeah.
Yes.
So Kanishka has
I'm
can you unmute him?
Rakesh ji, please unmute Dr. Kanish Davda, make him co-host.
Got it? Is he unmuted?
1 second, sir, I'm trying. Kanish sir can unmute himself.
Yeah, yes, he's unmuted. Kanishka, can you hear us?
Yes.
I'm stopping my screen share, sir.
Yeah, you just stop it for the time being.
Yes.
Presentation. Yes, sir.
Yeah, okay.
Yes, sir.
Yeah, go ahead, Kanishka.
Okay. So basically, I'll speak a little bit orally about diagnostic aspect. So there's always some confusion. What is the difference between gene expert, TB PCR, TB culture, MGIT culture, and what is the best way to diagnose GUTB, right? And then I'll go on to the treatment part. Is that okay, sir?
Yeah, please go ahead.
So see earlier the genetic tests for TB were not available. So we used to do urine AFB 24 hours and urine culture 24 hours, 3 times in the morning for 3 days in a row. And still we used to not be convinced whether it is truly there, not there, all those things. So now we have much better tests. Um, so there's a gene expert test, which is one of the main tests nowadays used. So it's basically a genetic test which looks for the TB DNA in the urine sample. And from that DNA, it also knows what mutations are present, what mutations are not present. So it can also comment on the sensitivity, right? So nowadays, urine AFB is not as useful as urine gene expert. One, the sensitivity is, so urine AFB, I mean just urine staining, right? Urine culture is different, that we have to do anyway. But urine AFB is not as useful as the urine gene expert. So urine gene expert should be the first test for any suspected case of GUTB, right? So the two advantages are that one, it is more sensitive, and two, it gives you the information about whether it is a sensitive or a resistant also, right? So that is the first initial step. You will also send the urine TB culture. Now, conventionally, we used to do in that solid media, LJ media, which we used to by heart in second year MBBS, right? Lowenstein Jensen medium, and it used to be pista green in color, and we used to see some colonies on it and all that. So now there are liquid media for culturing, which is called as MGIT media. So it is considered a little better. So we prefer the urine MGIT culture, TB MGIT culture, it is called as. If that is not available, then any culture is also fine. Solid media culture or conventional culture is also fine. But we have to do both. So we have to do the urine gene expert, which is a genetic test, and we have to do urine TB culture, which is a usual culture, which can again be in solid media or liquid media. Why we need to do both? Because the genetic test sometimes has some, some errors in it. So like the
Anissa, can
mutation.
you talk little louder?
Yes, yes, I'll talk louder. Uh, so the genetic test has some errors sometimes, right? So we need to do the culture, and then the usual way of doing sensitivity testing that can be done only on the grown culture. So we need to do both, not just one, right? So the reason that the genetic test sometimes has errors is that there are some mutations which are called as silent mutations. So they may code for, they may be called as resistant on the gene expert, but truly they are not resistant. They are sensitive, the bugs. So let us not get into the nitty gritty. Just wanted to share the basic thing with you. So the two main tests we do for GUTB in terms of microbiology are the urine gene expert and the urine TB culture. Right? We can do this 2 days in a row, morning sample to increase some sensitivity. And these are the basic thing about the diagnosis. Right? So regarding this, any questions, anybody?
No, you can go ahead.
Yeah. So I'll go ahead with the treatment part. So now TB can be sensitive or resistant. So this usually, if you are sending a urine gene expert, you know that it is either sensitive or resistant, and based on that, we can start the treatment, right? Now, H is isoniazid, right? R is rifampicin, E is ethambutol, and Z is pyrazinamide. If you go by milligram per kg, then it is little bit easy to remember. 5, 10, 15, 25 mg per kg, right? And for a normal 60 kg adult, it comes to approximately these numbers. So isoniazid 300 mg per day, rifampicin 600 mg per day, ethambutol 1200, and pyrazinamide 1500. So it comes as 750 tablet. We give it twice a day, right? And we give pyridoxine to prevent the isoniazid toxicity in the form of neuropathy and anemia and all that. right? So this is the regimen we use for the sensitive TB. Right now, the two most common. So now one more thing is that many of our patients may have raised creatinine. So what is the renal adjustment required? So isoniazid and rifampicin we give same dose. Whether it is ESRD not on HD or patient is on HD doesn't matter. The dose remains same for all patients. Whereas the ethambutol and pyrazinamide we use at alternate day and we dose post HD on the HD days. Right? So what are the side effects? The two main side effects are liver toxicity and vision. Right? So except for ethambutol, all three other agents can cause liver toxicity: rifampicin, INH, and pyrazinamide. Whereas the ethambutol can cause a vision toxicity, so blurring of vision and all that can be there. Now there are many more rare side effects, including sideroblastic anemia, INH-induced psychosis, drug reactions, skin reactions, interstitial nephritis, drug-induced cytopenias, and all that. But the two main ones we need to remember for urology are liver and vision toxicity. So now, since we know that these are the toxicities, you know how to monitor for them also, right? For we do CBC, LFT, RFT at 15 days, and then if everything is okay, then every 2 months also we can do. For the vision, we keep asking them, "Are you okay? Are you? Can you see everything properly or not?" And we can do ophthalmic check every once in a while, right? So this is about the sensitive TB. Very quickly, I will recap. 5, 10, 15, 25. HREZ. Huh? Pyridoxine to prevent some of the toxicity. Renal adjustment only in ethambutol pyrazinamide. Side effects are liver toxicity and vision, and many more rare ones. Monitor LFT, RFT, CBC, and vision. Right? So this is about the sensitive TB. Now we come to resistant TB. So resistant
The
TB,
period,
huh.
can you tell how many months we have to give it?
So we give 9 months minimum. 9 months is the minimum,
Okay.
not 6 months. 9 months is the minimum, but sometimes we may increase further. Suppose patient is post renal transplant. Suppose he had some intolerance to one of the main drugs like rifampicin or isoniazid, then we may extend up to 1 year because the patient is not having ideal treatment and also because patient is having immune suppression. So to prevent relapses, we may extend to 1 year, but minimum is 9 months.
Okay, fine. Go ahead.
Huh. So now we come to resistance. So resistant TB is basically MDR TB. It is defined as resistance to rifampicin and isoniazid. So bear in mind that patient may be sensitive to ethambutol and pyrazinamide. Still, it is called as MDR. So whether something is MDR or not depends on rifampicin and isoniazid sensitivity, not on the other first line agents. Right? Now things are much more complicated. So I would always advise all urology people to involve physician when they are treating MDR TB, especially, right? Because the drugs are much more toxic and the regimen is very long. So if you are giving incorrect regimen for long duration, then all sorts of problem can happen, including resistance and too much side effect, right? So 5 drug regimen is to be given for 6 to 8 months period, then 4 drug regimen for 10 to 12 months period to complete a total of 18 months of treatment. So 1.5 year it is, 1.5 year of treatment. And so we have to go by sensitivity as much as possible because it is even more important to do sensitivity testing and know the sensitivity when we are trying to treat MDR. So imagine if you are giving 1.5 year of treatment, but one of the drugs that you are giving or two of the drugs you are giving is not even sensitive. So you are putting the patient through 1.5 year of treatment and to inadequate or inappropriate treatment with side effects. The second line is much more toxic than first line. So be very careful. We have to do culture and sensitivity, especially in a resistant patient. Can't go just empirically, but till you get the sensitivity, empirically, what regimen you will start is generally this. So amikacin will start at 750 to 1 gram per day once daily. Levoflox at 750 per day, not 500. 750 is the minimum dose for TB. Now linezolid, the TB dose is 600 once daily, not the bacterial dose which is 600 twice daily, because that becomes too toxic and patient cannot tolerate. And for TB, this is an adequate dose. Then clofazimine 100 milligram once daily, ethionamide 250 TDS. So empirically, when you are awaiting the sensitivity, we start this regimen. And but if the sensitivity report comes and ethambutol or pyrazinamide are sensitive, then they should replace one or two of these drugs. Right? And
Okay.
so now what is the toxicity of so other options are then not very appealing. In these other drugs are having even more toxicity and other issues. So cycloserine, monopass, meropenem, clavulanate, these are the other ones available to us. Then from the government program, we can also have bedaquiline, delamanid, which are not available to the private practitioner, and pharopenem as a last resort. Right? So this is this thing. And side effects, much more side effects than the first line. So you have seizures, nephrotoxicity, neuropathy, blindness, cytopenia, lactic acid, many things are there. So you have to monitor everything every month. So minimum CBC, LFT, RFT we have to do, and we ask for many of these side effects, right? So this is this thing for MDR. Just to summarize, 18 months of treatment. First 6 to 8 months are 5 drugs, then 4 drugs, and this is the preferred empiric second line. Try to use sensitivity and involve the physician, and these are the other options, and a lot of toxicity. So I've just kept it very basic.
No, thank you. Because this is very important. Normally, in the exam, they just ask about the name of the drugs and the, like, some toxicity and the dose. So you
Yes.
have covered up everything and you have given a beautiful knowledge to all our students. Kanishka, thank you very much.
Thank you, sir. Thank you so much.
Yes. Okay, Achit, now you can share your screen and we'll now go ahead with the management. Okay, fine. Abhishek, now this is a scenario. Now what do you want to do?
Yes, sir. Sir, this like Ojas described, sir, this appears to, so there is a dilatation of the ureter. There is infundibular from above, sir, we can see there is distortion of the calyces, there is infundibular stenosis, there is hydropelvis, there appears to be the pelvis to be pulled up. There is a kink in the upper ureter also, sir. And moving ahead, sir, the entire ureter is dilated and appears characterless, sir. Means peristalsis cannot.
Abhishek, I'll tell you.
Yes, sir.
I'll tell you. What has happened is that now can you tell me what is the status of the right kidney?
I cannot see anything on the right kidney,
So
sir.
this is because this is nephrostogram, so you cannot see.
Yes, sir. Yes, sir.
But looking at CT scan, what you want to do for the right kidney and what you want to do for the left kidney and what you want to do further.
So for the left kidney, sir, I would want to, so for the left kidney, already PCN is there, sir. And yes, sir, with the PCN in place, I would like to start on AKT, sir. And right kidney.
So how many months later you will plan for the surgery?
2 months, sir. Once the induction phase is over, sir. After that only we will plan for any intervention.
Okay. So now what you want to do?
Sir, so for the
number one, you want to go ahead with any surgery or you want to do any other investigation?
The baseline assessment of the function is to be done, sir.
What do you want to do?
Nuclear scan should be done, sir, to assess the baseline function so that we can proceed.
Yeah. So I can show them. This is a nuclear scan. Tell me.
Yes, sir. So, sir, the parenchymal phase, sir, there appears to be no uptake, sir. On
in the right kidney, there is no uptake on the right kidney.
Side, sir. There is no uptake on the right side. Appears to be, and there is a I think delayed excretion on the left side also, sir. Yes, sir. But right side, definitely there is no uptake, sir. There is a non-functioning kidney on the right side, sir. So in that case, I would proceed with the right side nephrectomy. I mean, after completion of the induction phase, I would.
Yeah, so you have given the 2 months of treatment. Patient
Yes,
has
sir.
responded. He has put on weight, and he is feeling better. Now, what you want to do?
Yes, sir. Sir, then, sir, there also appears to be a stricture in the distal ureter on the left side, sir. So I would like to tackle both of them on the same sitting, sir. By
Abhishek.
doing, yes, sir.
Simple question. Why patient presented to you?
The patient presented with left flank pain, sir.
So what is the important side?
Left side, sir.
What will be the probable functioning side?
Probable functioning side is left side, sir.
So you want to tackle left side first, or you want to tackle right side,
Tackle the left side first,
or
sir.
you want to tackle both sides in same sitting?
Both side in same sitting because the
Why
right side,
you want to touch right side?
because the
What
right
is the
side,
indication of touching the right side?
yes, sir. Sir, because the right side may act as a focus of infection also, and otherwise also, sir, it may cause hypertension because yes, sir, hypertension. So
Dekho, end stage tuberculosis kidney with complication only need nephrectomy. Nephrectomy in a asymptomatic tuberculosis kidney, asymptomatic non-functional tuberculosis kidney is debatable.
yes, sir.
Removing a kidney which is asymptomatic, non-functional, but tuberculosis is debatable. So what are the indications of doing nephrectomy on right? But for this particular patient, my important side is left side.
Left.
In right side, if it is presented with complication like what? Sepsis, that means pyonephrosis, hemorrhage, intractable pain not responding to medical management, and drug resistance. In spite of
Hypertension.
treatment, there is no improvement on that particular side. This kidney is non-functioning. I agree. This kidney is non-functioning. This kidney is non-hydronephrotic. This kidney is asymptomatic. Okay. So at particular this point of juncture, there is no any urgency in treating right side.
True, sir.
Urgency here is to treat the left side. So on left side, n number of permutation and combination type that particular site may present. Suppose this patient had multiple infundibular stenosis with multiple all callosal dilatation with functioning kidney. What you will do? Another. Only one calyx dilated, grossly dilated, distorted. What you will do? Another condition. Third, whole ureter is atretic stenotic, but kidney is functioning, pelvis, hydropelvis, and both all the calyx are communicating. Third, only small segmental picture in the upper or lower ureter, particularly lower ureter. These are presenting the. Okay. So, what are the indications of nephrectomy? What are the indications of infundibulotomy? What are the indications of infundibuloplasty? What are the indications of ileal ureteric replacement? What are the indications of ileo-infundibular anastomosis? What are the indications of total ileal replacement? ये सब चीजें इसमें discuss होती.
Yes, sir.
So after listening this, go ahead.
Yes, sir. So the important.
Okay, Abhishek, I'll tell you something else. Meanwhile, this patient, by the time we did, and then we decided to call him, patient came with the difficulty in passing urine. Till now, he was passing urine also, and also he had nephrostomy. So he had difficulty in passing urine. He was not able to pass urine. His stream had become very thin, and he had lots of lower tract symptoms. So now what you'll do?
Sir,
And now actually the patient has undergone right nephrectomy.
Yes, sir. Sir,
So one question I want to ask, whether you do nephrectomy or you will do nephrouretectomy.
we want to do nephrouretectomy, sir. We want to remove as much of ureter as possible with the right side kidney, sir.
So if you are removing the disease part, you have to remove the whole thing, correct?
Yes, sir.
So what are the indications of nephrouretectomy? Just for the information.
Sir, most common indication for nephrouretectomy is, sir, urothelial, upper tract urothelial malignancy, sir.
Okay.
Yes, sir. And sir, sir, other genitourinary tuberculosis extending from.
Yes.
Then, sir, widespread.
Then third.
Lower ureter.
Reflux.
Reflux. Yes.
Reflux. Reflux. Yeah, reflux.
So always remember in exam the indications for, okay,
Yes, sir.
nephrouretectomy. So in this case, they have already done the right nephrectomy,
Right, sir.
and now patient has got lots of problem in passing urine. So what will do now?
Sir, I'll counsel the patient for an augmentation procedure, sir. I'll evaluate his complaint, sir. He's complaining of increased frequency, incomplete evacuation, and hesitancy with per urethral 200 ml per day, nephrostomy 1.4 liters. Yes, sir. So, sir, per urethral urine output, sir, whether he's passing the same amount of urine every time, how much is the frequency? I would want to characterize, sir. Then
He says that I have got a straining. I am not able to, my stream has become poor. Now what will do?
sir, we'll do a cystoscopy, sir. We'll do a cystoscopy to assess the bladder. Anyways, sir, if we are planning for an augmentation, we will require a cystoscopy to find
Already
out.
we have done cystoscopy earlier.
But that was 5 months earlier, sir. Now repeat we have to do, sir, because.
So anything else you can do?
Sir,
to study.
Yes, so just tell us.
yes, sir. So at this stage, first, I would like to know what is the culture report, final culture sensitivity report, because as we can see that the disease has progressed in terms of the bladder, we can see that the patient has got storage symptoms initially, which is didn't complain of. So I'd like to know what is the first culture report, what is the final culture report?
Don't try to treat the investigation. What sir is telling, patient had voiding symptoms. Difficulty in passing the urine. He is clearly saying difficulty in passing the urine. So low capacity bladder, how patient will have difficulty in passing urine? In spite that, he may have storage symptoms. If I am thinking by your way, if it is a low capacity bladder, storage symptoms are more.
Yes, sir.
Sir is asking, patient presented with difficulty in passing the urine. So why he may have small capacity bladder or always high pressure bladder? So damaging the kidney is again more chance. And presentation is always with the storage symptom. So in spite of thinking for the cause of that obstruction or difficulty in passing the urine, you are going the wrong way.
See, someone has put it.
Urethral.
So listen
Urethral.
first. What examiner is asking, listen it, analyze it, and then reply.
So now what do you want to do?
So I will then first do a micturating retrograde urethrogram and a micturating cystourethrogram to know the capacity of the bladder, and also if any stricture, any urethral stricture or any involvement of the bladder neck, anything is there. I would look for that by doing a MCU, RGU both.
Achit, just show them. On the left hand side is the earlier one.
Okay, bladder capacity is minimal. It looks like a very small capacity urethra. Bladder neck is this is okay. So bladder is completely fibrous, very small capacity, like a thimble bladder, and the bladder neck is also completely stenosed. This is the MCU in the MCU films, and in the RGU films, there is a
Just enlarge.
Well, smoothish.
The below one. Just show them the below one. Yeah. Still make it little bigger if you can.
Okay. At the bulbar urethra, so there appears to be there is a stricture, and bladder is complete, but there is some contrast going, so there is not complete occlusion, but at least 80 to 90% narrowing at the level of bulbar urethra. And bladder in the MCU films, we can see that the bladder is completely fibrous, contracted, very small capacity. It is more like a thimble bladder. It's minimal capacity, and bladder neck is also completely stenosed, and there's a bulbar urethral stricture.
So Abhishek,
And
now next
what is seen just distal to the bladder film, bladder image. It is a dumbbell shaped dumbbell in the original. So what
the bladder?
is what is in distal, what is in proximal, what is in mid?
Distal is the anterior urethra, proximal is the contracted bladder, and that in middle is bladder neck is completely stenosed.
Sir, without
the bladder is gimbal aggregate. Just distal bladder neck, maybe stenosis aggregate. Distal to the stenotic bladder neck, what it is? There is another white shadow.
Yes, yes, I don't know. That's sir, what it is. I don't know, sir.
And don't comment on RGU or prostatic urethra. Don't comment on posterior urethra on RGU. Don't comment on anterior urethra on MCU. Because it may be prostatic cavitation. If you are proximal to that, if you are thinking, it is in the area of prostate. If you are thinking it is a thimble bladder with bladder neck stenosis, if you are thinking it is a thimble bladder with bladder neck stenosis, distal to the bladder neck, what it is?
It's prostate.
Yeah. So anterior urethra right up to the mid bulb or distal bulb is normal. The mid bulb and proximal bulb is not seen on RUG. On MCUG or VCUG, it is a small capacity thimble bladder with probably bladder neck stenosis, which there may be he may have cavitation in the prostatic urethra, which is filled by the contrast.
Okay.
That may be possibility. We have to confirm it.
Yes, sir.
Sir,
So now, Abhishek, what you will do?
sir, without antegrade contrast study, we cannot comment on the bladder capacity also, sir, as well as the posterior urethra.
No, MCU. Commenting on bladder neck and prostatic urethra is possible only on the MCU.
Exactly, sir.
So that they are showing MCU only. First
Okay.
film attempted MCU.
Attempted MCU. That's what my doubt was, sir.
So in that attempt, whatever the contrast filled bladder, the contrast is coming in the posterior urethra.
So,
Posterior urethra means that is prostatic urethra. Just distal to the bladder neck, it is prostatic urethra.
yes, sir. Then yes, sir. Dilated prostatic urethra. Then.
So what are the points of dilated prostatic urethra? It may be pre-stenotic dilatation, or it may be post-stenotic dilatation, or it may be cavitation by the tuberculosis.
Yes.
So here situation again get worse. Left urethral
yes, sir,
stricture, thimble bladder, and involvement of the posterior urethra. Now, how will you proceed?
And the right non-functioning kidney.
Yes, sir. For the right side non-functioning kidney nephrectomy has already been done, sir.
Yeah, already done.
Yes, sir. And
But suppose this patient has got this and right non-functioning kidney, how will you go about?
So first we like to treat the stricture and the bladder part, because
Yes,
we have to preserve the left kidney. So first we like to treat with the stricture and
Do what?
so with
Now, if the
the,
patient is not passing enough of urine, what will happen? What will happen to the stricture surgery?
sir, he's not passing urine, sir, then we'll create a diversion, sir, in the form of suprapubic cystostomy, and then deal with the stricture, sir.
I,
Abhishek, here already PCN is done. The urine is not coming down. As
But
it is
sir,
diverted, as well as patient had a stricture in the lower ureter. So
yeah,
these are
yes,
the two things. Why
or
urine is not
we
coming
can,
down? Now
or the
that
patient, yes, sir.
left kidney function is already preserved by placing the PCN
yes,
temporarily.
yes, sir.
Now here three problems. One is the stricture, another is a small capacity bladder, and third is the prostatic urethra or urethral stricture. Ureteric stricture, urethral stricture, small bladder.
So then patient can be considered directly counseled for an ideal conduit, in which to anastomose the upper part of the ureter to a conduit and drain the urine. So that way. Ideal conduit would be better in this case, because
Augmentation surgery would be preferable because, sir, the bladder is more than, sir, 150 cc's of capacity. It's around 350 cc. So, sir, an
Nice.
augmentation would help.
After seeing this MCU,
this is 20 ml. It's hardly 20 ml. It's a thimble
what
bladder.
will be the capacity of bladder?
20, less than 20. This is very minimal. 14 to 16, 14 ml. So 15 ml.
Yes, sir. According to this, it will be very less. So then,
Ideal conduit would be better, sir. The anastomose before above the stenotic part of the ureter, the anastomose is with the ideal conduit.
agreed, sir.
Do you think this patient can pass urine per urethra now?
Very less likely. It's very less. The prostatic and the bulbar urethra is almost completely stenotic.
Do you think you can do surgery so easily?
No,
As
sir.
such, posterior urethral surgeries are very difficult.
And yes, sir. And then there will be dense fibrosis, sir, after receiving treatment.
So, what are the alternatives in this case? Can you keep the permanent PCN?
Not advisable, sir.
Not advisable.
So
Sir.
then, so you want to get rid of PCN?
Yes, sir.
So what you will do?
Ideal conduit, sir. Ideal conduit.
So I think in this case, what you say, Dr. Gite, in this case,
Sir,
it's not possible.
as bladder, if this bladder is very small capacity, less than 50 ml, and as posterior urethra is totally distorted, oblique, having a cavitation, so I am agreeing with Ojas, a small ileal conduit with left ureteric implantation in that ileal conduit will be minimum surgery and maximum benefit.
Benefit.
Agreed, sir.
Correct. Right, Abhishek?
Yes, sir.
Yes.
Agreed, sir.
Yes, sir. Yes, sir.
Understood? So
Yes,
how
sir.
to go logically? So many things
Yes,
you have learned. First of all,
Yes, sir.
it is not necessary. It is debatable that it is a non-functioning tuberculous kidney, but not symptomatic, not giving any problem, whether to remove or not to remove. That is number one. Okay. Second thing
Yes,
is
sir.
you may not give the best or the complete treatment to the patient, like in the form of urethroplasty, reconstruction of the bladder. So sometimes you have to look for the maximum benefit by minimum surgery.
Yes, sir.
So in this case, what will be the best for the patient?
Ideal conduit, left aortic reimplantation.
Conduit with the aortic reimplantation, sir.
Yeah. So that is the best you can do. Later on, you can decide what you want to do. Correct?
Yes, sir.
So this is the way. Okay. We have got 5-10 minutes. There is one short case also, if we can.
Yes, sir. Yes, sir.
Okay. हाँ बोलो.
और कुछ छोटी मोटी चीजें ट्यूबरकुलोसिस की फिनिश करते हैं.
बोलो
तो
तो.
what are the indication of partial nephrectomy in tuberculosis?
Yes.
Number
answer.
one.
Abhishek.
Sir, the indications of partial nephrectomy can be, sir, a focal granuloma causing damage to only one lobe. Number one. Secondly, a rapidly increasing size in granuloma increasing rapidly in size are the two indications for a partial nephrectomy in case of GUTB, sir.
The calcification localized to a particular pole,
In spite
sir.
of telling it as a lobe, we should tell like localized polar lesion.
Okay, sir.
Localized polar lesion containing calcification that has failed to respond after 6 weeks of intensive therapy.
Right.
Number
sir.
one. Number two, area of calcification slowly increases in size and threatening to the gradually destroy the kidney.
Correct.
These are the two.
Yes.
Okay. Question number two. If patient had a phantom calyx, that is detached calyx from the pelvic system, what will be the treatment? Calyx is functioning.
So, is ureterocalycostomy?
No, sir. Sir, PCN with infundibulotomy, sir. PCN with infundibulotomy, sir.
Infundibuloplasty,
Infundibulotomy.
infundibulotomy, or calycotomy.
Okay.
Yes, sir. Sir.
Suppose question. Bolo, pucho.
Yes, sir. Sir, in case of phantom calyx, sir, do want to do a PCN into the phantom calyx, establish a drainage system, and then do a infundibulotomy and plasty following that, sir.
Agreed. Another thing is multiple calyceal infundibular complete stenosis, but kidney is functioning. What will be the treatment?
Yes, sir. So in that case, we will open the kidney by the lateral border, sir, like a book, and then, sir, go in with the balloon, do a infundibulotomy on all the calyces, and then, sir, hitch the adjacent sides of two infundibulum together, sir, so that they remain patent, sir, like that.
So opening the kidney on laterally and anastomosing all the calyceal infundibulum after opening it to the ileum.
Yes, sir.
If all the infundibulum is totally stenosed, then how you can communicate all this infundibulum to one ureter? It is not possible. So you have to use ileum. Open the kidney, place the ileum inside the kidney, and anastomose with the infundibulum, open infundibulum of all calyces. And that ileum to the ureter, if ureter is normal. If ureter is also abnormal, same ileum can brought down to the bladder, provided that bladder should be normal. Role of steroid in tuberculosis.
So TB meningitis and TB pericarditis, survival benefit in genital tuberculosis, controversial.
Okay. Then comment something on transplant with transplant patient prophylaxis in tuberculosis.
Okay, sir. In transplant patients, sir, rifampicin cannot be given, sir, because rifampicin is enzyme inducer, sir, and it will cause decreased concentration of tacrolimus, cyclosporin, and hydrocortisone. So, because of that, sir, there is increased rate of graft rejection. For that case, sir, we can, if it has to be given with cyclosporin, sir, then we have to double the dose of steroids, sir, in that case.
So, what is the incidence of tuberculosis in transplant kidney?
I think around, I'm not sure, sir, around 60%, I think.
60.
Abhishek, you are doing 100 transplants in a year.
No, sir, 1 to 2%.
How many in last 2.5
How will you
years?
manage tuberculosis prostatic abscess? Reported incidence of tuberculosis in transplant kidney in India is there about approximately 10%, 9.5 to 14%. Average is 10 to 11%. Management of tuberculous prostatic abscess.
Sir, management of tubercle prostatic abscess can be done by transurethral route, sir. It can be drained by a transurethral route, and with cover of antitubercular medication, sir.
Why not per rectal aspiration?
Sir,
It will form a fistula.
form of fistula.
As a
Yes.
fistula would be high, sir.
Urethra is a little more resistant to tubercular infection.
Long tubercular stricture in the upper ureter.
Long tubercular, sir, upper ureter long tubercular stricture can be best managed by a Davis intubated pyeloplasty, sir.
Any alternative option?
And
Ideal substitution.
ileal replacement can be done.
Ideal
Long
replacement.
means that not long means that much not work. Some the provided that it is 3 centimeters. Suppose it is 5 centimeters. Suppose it is 8 centimeters. So if it is long but not possible to bridge the gap with pelvis, then ureterocalacostomy. Long but not possible with ureterocalacostomy, then
Auto-transplantation. Bring the kidney down.
then
Nephropexy.
Davis intubated or ileal replacement. And if whole stricture is gone, total ileal replacement.
Yes, sir.
Okay.
Yes, sir.
Then what are the indications for auto transplantation? You told auto transplant. What is indication auto transplantation?
Sir, auto transplantation when sir the entire ureter is
Why you want to do auto transplantation?
sir,
Why you want to disturb the normal vasculature of that kidney?
If a very long segment ureteric stricture
Tell me.
and
Dekho,
not willing for
Telling
yes, sir.
something in exam, think twice before telling.
Yes, sir.
Replace with IDM. Why you want to unnecessarily disturb that normal vasculature? So, what is the autonephrectomy? Tuberculous autonephrectomy. What is the tuberculous autonephrectomy?
Yes, sir. Autonephrectomy, sir, is a sequel of advanced tuberculosis where the kidney is destroyed by the own inflammatory procedure. This can be two types, sir. It can be fibrotic or caseocavernous. So when the kidney is filled with when there is extensive parenchymal damage with the cavernous cavities formed in the kidney filled with inflammatory exudate, that is caseocavernous, and when the kidney has formed a small fibrotic mass with the parenchymal damage, it is known as the fibrotic autonephrectomy, sir.
Okay, what is in the putty kidney?
Yes, sir. Putty kidney. Yes, sir. Cases.
Backfilled with pus. Backfilled of pus or caseous necrosis in case of tuberculosis. That is putty kidney. Completely destroyed renal parenchyma.
Is AKT safe in pregnancy?
AKT is safe
yes,
in pregnancy, sir. Yes, sir. Dose
Except
streptomycin and rifampicin might need some dose modification.
streptomycin is anyways out of the first line now.
okay. Then lower ureteric stricture, as like in this case.
Can be tackled with a psoas hitch, or sir, assuming the psoas is normal, sir.
Provided bladder
and
is
the
normal.
bladder is the bladder is has a good capacity, sir. Else
Suppose
also
bladder is not in good capacity, then
bladder is not in good capacity, then sir we can do a ureteric reimplantation, or if there is tension
how will you do ureteric reimplantation if bladder is not good capacity?
Augmentation cystoplasty and then ureteric
Yes.
implantation.
Augmenting with ileum and one limb of ileum to be connected to the ureter.
ureter.
So this in short, I feel everything about tuberculosis.
So one doubt I had. So starting में will we do a DTPA scan as a baseline or will we not do in the initial part when the patient came
If,
for evaluation?
if the patient had a deranged renal function, if patient had a deranged renal function, and by decompressing the system, if you are thinking that kidney function is going to improve, better to do a decompression first and then go for the DTPA.
Oh, yes.
So I think we should stop here, Gite.
Okay, if everybody पूछना है तो
Or if you want, we can just show the one small case and finish
बोल
it
दो,
off.
5-10 मिनट का है तो बोल दो.
Yes, Achin, just show them. The patient came, I'll give you the short history. This patient came with the pain in the left flank region and he had fever also. And so we investigated him. Okay, just show them. Yes, positive findings. Achin. Sonography, the left-sided gross hydronephrosis with cortical thinning and proximal ureteric calculus. These are the findings. So next we did the CT. Show the CT. Okay, fine. Now can anyone comment on that fast?
Right kidney appears normal cortex, CMD difference, normal cortex and normal parenchyma. Left kidney is dilated, grossly enlarged kidney with entire dilatation of the calyceal system with cortical, complete cortical thinning, and we can't visualize the ureter is also not seen. The PUJ at the level of PUJ also. There is no excretion of the contrast only, rather no uptake by the only minimal cortical uptake of the contrast.
It appears
Just Dr. Maheshwari had told you so many good things. Just see on the normal side, right hand side, show that field. Can you see on the right hand side? Are you happy with the total right? Is it absolutely normal?
There is good cortical thickness, good contrast excretion.
But calyces are absolutely normal. The ureter is normal.
Yes, sir. Yes, sir. Correct. Absolute normal. Ureter is normal. Yes, sir. Prompt good excretion of the contrast. Looks good, sir. On the right side looks good. Left side.
Calyces are concave or convex. If there is a fullness or not. And the lower ureter, just see the lower ureter. Can you see the stenosis at the junction of lower 1/3 and middle 1/3? So right side is not absolutely normal, as you can see.
Okay, sir.
And the
Okay.
left side, can you see the dilated pelvis? Is it
Yes, sir.
possible? Are you seeing
Left
it?
side. Yes, sir. Yes, sir. It's intrarenal.
So calyces are more cystic, more dilated than the pelvis. Pelvis is hardly seen.
Hardly seen.
And
It's,
do you think that small calcification or calculus in the ureter can be the cause of obstruction?
No, sir. No, sir. Very.
So it is a calcification or a stone?
It could be a calcification on the ureteric wall, sir. More likely.
So now what is the diagnosis?
Sir, findings are of a left-sided non-functioning kidney and right-sided lower ureteric stricture. The primary diagnosis I would like to confirm on further investigations.
Okay. So we did, patient wanted only not removal of the. Okay. So what are the next investigation like to do?
I will start with the past history, sir. Past history and
Past history, he had a tuberculosis in past.
sir, then we are suspecting tuberculosis. Then I would like to do a chest X-ray, the urine routine microscopy, urine culture, urine for AFP smear, urine for gene expert, and urine for gene expert. Yes, sir. I'd like to proceed with all this.
Okay. Achin, we have got any other investigations apart from this? Okay, renogram was done. It was showing non-functioning kidney.
Non-functioning.
Yeah, absolutely non-functioning kidney.
No function at all. Yeah. He doesn't have any symptoms on the right left side, mainly right side pain. So first, creat is also normal in this case. So, and if we get the based on the culture report, first I would like to see what the AFP smear and the CBNAT report is, and then accordingly proceed, sir.
Why you want to, accordingly, you want to proceed? This is the
Yes, sir.
left-sided non-functioning kidney.
Yes, sir, but the patient has primarily come with right side pain.
Ojas, in spite of
Yes.
telling urine for AB, culture, ये वो, एक protocol दिमाग में बिठा दो. I will go for urine for DNA TB PCR because it is rapid. It will give result within a few hours. Sensitivity and specificity is more than 90. If that doesn't give me my required answer, then I will go for another. तो फिर तो n नंबर ऑफ है, फिर बैक टेक भी करो, फिर कल्चर भी करो, फिर ए भी कल्चर भी करो, पीसीआर भी करो, हेड स्टेनिंग भी करो, तो सभी कर दो.
Okay.
कुछ तो प्रोटोकॉल होगा ना.
So
हर एक
gene
के पास
expert
एक
did
प्रोटोकॉल
show
है.
positive.
Urine TB PCR has shown positive. No? So then I would like to start the patient on get a DTPA scan done for the left side non-functioning kidney. We have confirmed that already. So I will
Yeah.
start the patient on AKT, sir.
Okay, and
Start
then
the
after
patient on
AKT, what you'll do?
After AKT, I will proceed with left first right lower atrial stricture. Now I will again like to do a repeat imaging to see basically sonography to see how much is the hydro, if there is any extension of the hydronephros on the right hand side, because you can see a right lower
Right hand
atrial
side is same, and the left side is still patient. As a patient had a fever, patient had a pain. You want to do anything to left side, or you don't want to do anything?
left
So
side.
right side, you are seeing contrast coming down. There is some lumen left. You wanted to get completely obliterated, or would you like to place
Sir,
a DJ stent and give
after
AKT?
so after intensive therapy, I will go ahead with DJ stenting.
Why
So
not
first you'll
before?
put a DJ, or later on you'll put a DJ?
Later on, we'll
Ojas,
put a DJ. Yes,
simple
sir.
question. How the anti-tuberculosis treatment is a type of chemotherapy. So how it will help?
Are there some
How,
papers where they say
that,
put
how
DJ
that
and
anti-tuberculosis therapy will work by doing what?
Anti-tuberculosis treatment will help to reduce the inflammation of the tissues. So in the cause of the lower atrial stricture on the right hand side, you see the narrowing could be because of mucosal edema as well. So
Another way of asking the question: after giving the anti-tuberculosis treatment, is this stricture is going to improve, or is this stricture is going to deteriorate? Or another way, you want to place the digestion and give anti-tuberculosis treatment, or you want to don't want to place the DJ and give anti-tuberculosis treatment?
third way, is there any evidence that placing DJ and giving AKT? Have you read any papers like that?
so I have not read any papers, sir.
That is why sir is asking you all these questions. So first question you answer, sirs, whether the inflammation will increase or reduce, whether the stricture will increase or reduce by giving AKT.
So if it was primarily mucosal edema, then it would reduce. If it is fibrosis, then it would progress.
What was sir's second question?
DJ first or DJ later?
Yeah,
Uh,
answer.
So in the initial setting, I will also like to do a cystoscopy and RGP and see.
You're done.
Different, bhai, you read
Sir,
up
we are
for-
asking you a specific question. You want to put
Yeah.
DJ first, or you want to give anti-coag treatment, and
Sir,
then you want
DJ.
to?
Sir, we'll put a DJ stand first. DJ stand first, sir.
Yes, you want to give DJ stent first because the fibrosis may take place, and there may be a total obstruction, and you may lose
Yes,
that
sir.
kidney.
Yes, sir.
Okay.
So
DJ stand
Yasir has
first.
said that it may increase or decrease. That is why I'm saying that when you're seeing the lumen,
Yes, sir.
you
Yes,
have a
sir.
window of opportunity now.
Yes, sir.
So
Yes,
try
sir.
to find out some evidence.
In cases of the early ureteric disease, how you should answer? In cases of the early ureteric disease, better to place DJ, wait for 6 weeks. If there is no improvement, then go for further treatment. ये early ureteric disease है, पूरा luminal compromise हुआ नहीं. तो लुमिनल
sir.
कॉम्प्रोमाइज होके किडनी जाने तक राह देखेंगे कि उसको सिक्योर करेंगे?
I will secure it first. We put a stent. Yes.
हाँ.
Yes, sir. Put a silicone stent preferably or whatever. Yes.
When you talk other things, now examiner knows
Yes,
that you
sir.
don't know the answer. You have to be
Yes, sir.
very. If I am asking you a specific question, you must answer very specifically.
Yes, sir.
When I
Yes, sir.
ask you, okay, do digest first or medicine and then digest later. So your
You
answer will be
search,
very
you
specific.
search today only for PubMed and see the evidence.
Yes,
Don't,
sir.
both of you don't
Yes.
leave it like that, so that you finish the topic
Yes, sir.
and tell us next time what you have read.
Yes, sir.
So anyway, what we did was he was not willing for anything else except for the website, and he said no nephrectomy, newly married. So I did a cystoscopy, RGP. There was a total obstruction in that area, but somehow I could pass the glide wire. I dilated the ureter. There was a calcification. We had put the digest and patient is not willing for anything else. So after 3 months, we have removed the digest. He has not come for follow.
Okay.
Okay.
Yes.
Yes, sir.
Okay. So in this case, what are the criteria to prove that it's a tuberculosis, TB?
Imaging finding is positive. That is one major criteria, and second is that we have urine AFP, the TB PCR positive. No, sir, yes, sir. So those two major criteria satisfied.
And patient gives a history of TB in past.
History, of course, that is yeah, that is also that is minor criteria.
After completion of 2-hour dissection, 1 major and 2 minor is required.
Yes, sir.
Yes, sir. In this case,
There is no confusion. 1 major and 2 minor required means required.
One major PCR
One major,
positive
one
is there, sir. One minor
and two minor.
radiological this thing is there, sir.
Radiological is there and history is there. So one major and two minor is satisfied.
Okay.
I think we have completed quite a lot of things, right, Dr. Gite?
Yes, sir.
Yes.
लगता है
Then, and Maheshwari, if he is there, he wants to ask last anything.
नहीं सर शायद लीव कर गए थे.
Okay. Okay, Hiren, anything you
Yes, sir.
want to say?
Good night, sir. Good night,
Okay.
Gite sir.
Good night, sir. Good night.
Good night.
Good night, everybody.
Yes.
Good night, students.
Both of
Thank
you
you,
are
sir.
answering
Thank
very well. I want other students also to join and please answer. It will really help you a lot.
Please
Yes,
read all
thank you.
your doubts and complete the topic today
Yes, sir.
only and
Yes,
tell
sir.
us
Yes,
next
sir.
time.
Yes,
Tell
sir.
us.
Yes, sir. Yes, sir.
Please
Yes, sir.
tell us. Okay, bye.
Okay.
Yes, sir. Yes, sir. Thank you, sir.
Good night.
Good night, Hiren,
Thank
sir.
you.
Good night,
Thank
Good night, sir. Good night. Bye.
Good night, Gite,
Thank
sir.
you, sir. Yes.